Good morning, Mr. and Mrs. Collins. My name is Dr. Clark. It's so nice to meet you. I would like to introduce you to my team of specialists.
I'm Lindsay Nye, nurse practitioner.
I'm Vicki Johnson, nurse practitioner.
I'm Leakin Pedro, nurse practitioner. And you guys already know me. I'm Bobby Moore, your family counselor.
And we would love to hear about your daughter, Catherine. That's why we hear you're in today.
Right. Catherine has been having some abdominal pain lately. She complains of lower back pain. I've noticed urine, blood in her urine, and we're just concerned about what's going on with her.
We were really scared, so we took her to our local hospital where they performed an ultrasound, and she was diagnosed with polycystic kidney disease. And after doing a little more research, we're pretty scared because it turns out that these cysts can move to her liver and the pancreas. It can cause diverticulitis, aneurysms, and even warp her heart valves.
Well, y'all are right. Your daughter has been diagnosed with PKD, and actually we've been running some tests on you, and you've both tested positive for a mutation in your PKHD1 gene. So what we're going to do today is just explain to you exactly what's going on with your daughter, exactly what this means, y'all having this mutation in your gene, and clarify things a little bit for you. So I'm going to turn this over to my team of specialists.
PKD is actually the most common life-threatening genetic disease. It affects 600,000 people in the U.S. and 12.5 million people worldwide. 1 in every 500 to 1,000 people will be diagnosed with some form of PKD. It affects all ethnic groups equally, men, women, adults, and children. It is also the 4th leading cause of kidney failure. There are 3 forms of PKD. Autosomal dominant PKD, which is the most common form. It affects 90% of all patients who have been diagnosed with PKD. If one parent has either the gene for PKD1 or PKD2, which means they have polycystic kidney disease, there's a 50% chance that their child will get this disease, and symptoms usually show up at ages 30 to 40. There's also acquired polycystic kidney disease, which is found in long-term kidney patients, especially if they've been on dialysis. But the form of PKD that your child has been diagnosed with is autosomal recessive polycystic kidney disease. It is a rare inherited form. So as your testing showed, both of you have tested positive for the abnormal PKHD1 gene, which means there was a 25% chance that your child would have come up with this disease. Not all patients of PKD will go into kidney failure. About 50% do, and the main risk factors for this are men, those diagnosed with autosomal dominant PKD, those with increased blood pressure, patients with protein and blood in the urine, and women who have an extremely high blood pressure and 3 or more pregnancies.
I'll just explain to you guys a little bit about what happens in polycystic kidney disease. Polycystic kidney disease is just that. Poly means many, cysts. You have a formation of many cysts on your kidneys, and there are 3 processes for this cyst formation. The first being tubular cell hyperplasia, which just means that the cells of the cyst, they're many cells, and they just continue to grow. And there are many factors that contribute to this, and it could be from uncontrolled cell proliferation or dysfunctional apoptosis, which is the cell's ability to automatically stop growing. The second type of formation is tubular fluid secretion, which comes from like a solid tumor cell, and it's transformed into fluid-filled cysts. The third type is just abnormality into the tubular extracellular matrix, and this is thought to be responsible for the hyperplasia or the abnormal growth of the cells that contribute to the cyst. In autosomal dominant PKD, there are 2 genes, which is the PKD chromosome 16, which and also the chromosome 4. And these cysts can grow enormous, up to about 22 pounds. They eventually start in like the nephron, which is a part of your kidney, and they separate and grow in other parts. Your type of PKD that Catherine has, autosomal recessive, as we said, it's a rare type, and it's caused by a different type of gene than the autosomal dominant PKD. And that gene is the PKDH1, which you both have been tested for, and you do carry that trait.
Unfortunately, there is no cure for recessive kidney disease, so treatment modalities are more geared towards easing the symptoms and prolonging life. To handle the pain that you described, we would provide over-the-counter medicines such as Tylenol. Now, if those don't work, we will use more intense painkillers if necessary. And also surgery, you can use that to shrink the cyst, and this can be used to relieve the pain also, but this is just temporary and it doesn't slow down the progression of disease. I heard you mention blood in her urine. This probably caused the urinary tract infections, which is very reoccurring in recessive polycystic kidney disease. Treatments with antibiotics can be used. Treatment should be done rapidly because the infection can spread to the kidneys and all other organs. Keeping high blood pressure at normal levels can also slow down the progression of this disease. This can be attained by lifestyle changes, maybe getting her in some type of volleyball, soccer, something like that. And also pharmacological treatments can be used such as diuretics, beta blockers, ACE inhibitors, and calcium channel blockers. Unfortunately, after several years of having recessive polycystic kidney disease, the kidneys may fail in function, and this occurs in 50% of the people. And due to the fact that our kidneys are essential for life, two options may be used, which may be dialysis or a kidney transplant. And in your case, your daughter has autosomal recessive kidney dysfunction, so symptoms show up much earlier in life. And in addition to all these, children are also encouraged to eat nutritious foods. Make sure you monitor her diet strictly. And also the addition of hormones can be used for the growth factors.
Well, Mr. and Mrs. Collins, we want to help your daughter, so what we're going to do is we're just going to ask you to step out of the room for a little bit. We're going to deliberate and come up with some treatment options that we think are going to be effective for Catherine. Thank you so much for coming and talking to us today.
Thank you.
Ideas that we want for you to infiltrate into Catherine's life to help with her polycystic kidney disease. One of them is we want you to keep your daughter active. Don't let her sit around at home all day watching TV. It's very important that she be moving around, getting that blood circulating. We also want you to be using Tylenol for her pain control. If that doesn't work, we'll put her on something stronger. We'll work that out later, but start with Tylenol. We also need for her to be on a low sodium and potassium diet. This is very important. We're also going to be putting her on an ACE inhibitor called
Captopril.
And we're going to be monitoring her kidneys for further cyst development. So every 3 weeks we need y'all to come back. We're going to keep running tests. If needed, we'll put her on a growth hormone, but we'll wait to see about that. So we'll see you in 3 weeks.